Good evening to all of you. So, last two lectures, and this is now the important topics in echocardiography, assessment of systolic and the diastolic function of the heart. So, we will take up diastolic dysfunction first because it is a little more difficult to understand. It may take a little longer time. So, always don't think about diastole and systole as a separate thing. Both the things are coupled together. As you can see, the actin-myosin bands gets attached to the receptor sites, and calcium is involved in the contraction and relaxation cycle of the heart. So systole and diastole are combined together. So actually one of my friends today asked me, say in all the patients with diastolic dysfunction, is there systolic dysfunction also? That is, in patients with heart failure with preserved ejection fraction, you get predominantly diastolic dysfunction. Is there a systolic dysfunction or not? And the reverse one, in patients with reduced heart failure with reduced ejection fraction, the systolic function is abnormal. Is there a diastolic dysfunction in some of the in all the patients or not? I don't know whether you have to tell me the answer last. This is actually based on recommendations for assessing the diastolic and the systolic functions of the heart, combined recommendations from the American Society of Echocardiography and the European Society of Cardiovascular Imaging. The assessment of left ventricular diastolic function should be an integral part of routine examination, particularly in patients with dyspnea and heart failure. This is one of the older classification, grade 1, grade 2, grade 3, and grade 4, based on the left atrial outflow pattern, tissue Doppler imaging from the mitral and septal mitral annulus, and the pulmonary venous flow pattern. You can use the flow propagation velocity also. This is the typical E wave, which is smaller than the A wave, and here the E velocity is decreased in the tissue Doppler from the septal mitral annulus. The E velocity of the pulmonary vein is higher than the S velocity is higher than the E velocity. So this qualifies for impaired relaxation. The second one is the pseudo-normal pattern, where the E and A wave looks like a normal one, but if you look at the tissue Doppler, the E velocity is decreased below 7 centimeters, and the pulmonary vein shows a smaller S wave and a taller D wave. So this qualifies for the pseudo-normal pattern. The third one is the restrictive filling pattern, where the E wave is very tall and the A wave is very small. Again, the E of the septal tissue Doppler is reduced. The S wave in the pulmonary vein is very, very small, and the D wave is markedly increased. These are the three type patterns which are described. But the problem with this is this typical pattern is not obtained in all the patients. In about 30 to 40% of the patients, you cannot determine what is the type of diastolic dysfunction and all that. And it was more cumbersome because we had to look at the mitral annulus flow, tissue Doppler flow, pulmonary venous flow, and sometimes you have to get other parameters. Even in the mitral valve, we had to measure the E velocity, A velocity, deceleration time, isovolumic relaxation time, too many measurements, and there will be variations and all sorts of confusion will be there. To avoid all these things, they came out with a newer advice in 2016, which is little more practical, and it is little easy to follow also. Here it is more simplified, and what we are looking at in diastolic dysfunction, the main thing is look for impaired relaxation, whether the patient has got impaired relaxation, that's the initial stage of diastolic dysfunction. And then in addition, does the patient have chamber stiffness also? This is a little more advanced stage of diastolic dysfunction. Along with that, does the patient have elevated filling pressure? This is the most important one. It is not enough if you say there is diastolic dysfunction. we have to say whether the left ventricular end diastolic pressure is normal or increased. When we say diastolic pressures, there are too many pressures. There is a pulmonary capillary wedge pressure, mean LA pressure, LV pre-A pressure, and LV end diastolic pressure. When we say elevated pressures, we always mean LV end diastolic pressures and not the other ones. So here you can see the pre-A pressure, this is the mean pressure, and this is the LV end diastolic pressure. Here when we say in diastolic dysfunction with the elevated left ventricular pressures, we always mean the left ventricular end diastolic pressures. Okay. What are the parameters to identify the diastolic dysfunction in patients with normal ejection fraction? This has been very much simplified now. So look at the left atrial outflow velocity. You have to keep the sampling volume in between the anterior and the posterior leaflets, get the flow pattern. Measure the E velocity and the A velocity. That's simple. And get the E by A ratio. Second, look at the tissue Doppler from the septal mitral annulus. Measure the S velocity, E velocity, and A velocity. The important thing is the E velocity. And measure the velocity from the lateral mitral annulus. This is lateral, this is medial. So you can measure the lateral and the medial mitral annulus. Similarly, the S, E, and A, the three velocities. The third one is the ratio. You can divide the LAOT E velocity divided by the E velocity in the tissue Doppler. So if you are using the septal annulus, the ratio should be more than 15. If we are using the lateral mitral annulus, it should be more than 13. If we are using both the average of lateral and medial mitral annulus, it should be more than 14 to call it as a diastolic dysfunction with elevated left ventricular end diastolic pressure. The fourth index is the volume, left atrial volume. This can be obtained from the apical four-chamber view and the apical long axis view, or you can use the apical two-chamber view also. This is by using the area length method, measuring the area of the left atrium and the long axis diameter. We can use even the Simpson method, or if you have a three-dimensional echocardiography equipment, you can use three-dimensional echocardiography for the measurement of left atrial volume. The last one is the tricuspid regurgitation velocity, which should be more than 2.8 to call it as a positive sign. So there are only four parameters which you have to measure. Left atrial outflow velocity, tissue Doppler from the median and lateral mitral annulus, calculate the E by E bar E prime. The third one is the left atrial volume, and the fourth one is the tricuspid regurgitation velocity. If you have done this, then you are ready to diagnose diastolic dysfunction and classify it. Look at this pattern, the LA outflow pattern. This LA outflow pattern shows that the E velocity is smaller, A velocity is higher. If the E velocity is 50 centimeters or less, with E by A ratio less than 0.8, then it is type 1 diastolic dysfunction. Can you understand? So E velocity should be less than 50 centimeters and E by A ratio should be less than 0.8. Then it is type 1 diastolic dysfunction. You need not do any other measurements. That's all, it is over. In both reduced ejection fraction with heart failure with reduced ejection fraction, in heart failure with preserved ejection fraction, this pattern, you have to, but the E velocity should not be 60 or 70 and the A velocity 80 or 90 and all that. It will not be qualified for that. The E velocity should be very low and the E by A ratio should be less than 0.8. Look at this pattern. So this is the LA outflow pattern which shows a markedly increased E wave and a very small A wave. And the ratio is more than 2. So here, this immediately tells you that the patient has got a type 3 diastolic dysfunction and impaired LV relaxation and chamber stiffness, elevated left atrial pressure. So when you get this pattern in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, this pattern always indicates that the patient has got a type 3 diastolic dysfunction, grade 3 diastolic dysfunction. Is okay? These two are quite simple. Only thing is the next one. Now, the E velocity is 70 centimeters in this patient. Even though the A is bigger than E, the E velocity is 70. So this will not qualify for the type 1 function straight away. And here you can see the E velocity is higher, the A velocity is smaller. So this looks like a normal pattern. And the ratio is between 0.8 to 2.0. E by A ratio is between 0.8 to 2.080. So in these patients, to say whether they have a normal diastolic function, type 1 diastolic function, or type 2 grade 2 diastolic dysfunction, we should have some other parameters. What are the other parameters which you should have? These are the other parameters which I have already described to you. So you have to find out whether these parameters are present. So in patients with normal ejection fraction, if these 4 parameters, out of these 4 parameters, if only one is positive, then the diastolic function is normal. If 3 or 4 is positive, then there is type 2, grade 2 diastolic dysfunction. When there is 1 or 2 positive, the diastolic dysfunction is indeterminate again. So instead of, if you are not able to get all the 4 parameters, you are able to get only 3 parameters, then it is going to be different. So in this indeterminate patients, sometimes we can use the peak global longitudinal strain. If it is decreased, again it indicates, supports the diagnosis of diastolic dysfunction. If only 3 parameters are present, here you can see, this is the mitral flow pattern. I told you initially the E wave is 50 centimeters or less, and the E by A ratio is less than 0.8. It immediately qualifies for type 1 diastolic dysfunction. This E is very markedly increased and A is very small and the ratio is more than 2. It qualifies straight away for the grade 3 diastolic dysfunction. When these 2 are not present, then we have to look at the other criteria. If by using the 4 criteria we have seen again, say when 1 criteria is present, then it is normal. When 3 or 4 is present, then it is grade 2 diastolic dysfunction. Only when 3 criteria are available, 1 criteria we are not able to get. For example, that there is no tricuspid regurgitation velocity to assess. Then if it is so, then if only 1 is positive, then it is likely to be a grade 1 diastolic dysfunction. If 2 is positive, then it is likely to be a grade 2 diastolic dysfunction. If only 2 criteria is available, then if one is positive and 1 is negative, we cannot determine the diastolic dysfunction. If both the things are positive, then it indicates that the patient has got grade 2 diastolic dysfunction. So only when it is not typical grade 1 or typical grade 3, then it becomes a problem. We have to rely on the 4 parameters, and depending on even if you are not able to remember this 1, 2, 3 and all that, more number of parameters which are positive, then more likelihood of their diastolic dysfunction. Less number of parameters are positive, then less likelihood of diastolic dysfunction. Less parameters are positive, then it is likely to be a milder degree of diastolic dysfunction. At least this one you should be able to remember. So no parameters are positive or less parameters positive, then it may be normal diastolic function. If 1 or 2 are positive, it will be mild diastolic dysfunction, it will be grade 1. If 3 or 4 are positive, it will be grade 2 diastolic dysfunction. Of course, grade 3 diastolic dysfunction will require this pattern, the early outflow pattern. Apart from this, we have some other criteria also for supporting the diagnosis of type 3 diastolic dysfunction. In patients with atrial fibrillation, in mitral valve disease, left ventricular assist device, and ventricular pacing, we cannot use these criteria. And there are certain other diseases in which it is, say, assessment of diastolic dysfunction is going to be much more difficult. There are certain other parameters which can be used. One is the deceleration time. If you see this E wave, the E wave comes down very fast. It is less than 160 milliseconds. If the deceleration time is less than 160 milliseconds, usually it indicates a type 3 diastolic dysfunction with an elevated left ventricular end diastolic pressure. The second one is presence of another wave between the E wave and the A wave. You see another wave between the E wave and the A wave. It was described by Dr. Liv Hartley. It is called L wave. If there is a prominent L wave with more than 50 centimeters, then again it indicates that the patient has got type 3 diastolic dysfunction with elevated left ventricular end diastolic pressure. And look at the pulmonary venous flow pattern. If the E wave is if the S wave is very small, again it indicates that the patient has got type 3 diastolic dysfunction with marked elevation of the left ventricular end diastolic pressure. And the additional one is the global longitudinal strain of the left ventricle. The global longitudinal strain in a patient with normal ejection fraction again supports the diagnosis of diastolic dysfunction. How will we report diastolic dysfunction? We can report it as normal diastolic function and normal filling pressure, if everything is normal. Grade 1 diastolic dysfunction is impaired relaxation with low to normal filling pressures. Grade 2 diastolic dysfunction will be impaired relaxation with chamber stiffness, resulting in moderate increase in filling pressures. Grade 3 diastolic dysfunction, which is the restrictive pattern, there is impaired relaxation, increased chamber stiffness with marked elevation of the left ventricular end diastolic pressure. So these are the grade 2 and the grade 3 are the patients in whom, if the ejection fraction is normal, they will qualify for heart failure with normal ejection fraction. Okay. Anything, any doubts about the systolic function, you can ask me. We'll go to the systolic function. Systolic function is little more easier for you to understand. And these guidelines were published in 2015, say assessment of cardiac chambers, dimension and function. And it is accepted that 2D is the accepted practice for volume analysis today, with acknowledgement that 3D is superior. So all the measurements should be done from the 2-dimensional echocardiogram. And if you have a 3-dimensional echocardiogram, use it for measuring the volumes and the ejection fraction. If the left ventricular measurements, left ventricular global function, left ventricular regional function, and left ventricular mass, these are the most important things. You can use say M-mode echocardiography for measuring the left ventricular internal dimension in diastole and systole. But you should use the 2-dimensional echocardiographic guidance and cut the interventricular septum and the left ventricular posterior wall perpendicularly like this. If you don't do that, then you will artificially produce an increased diameter. So if you cut like this from an oblique picture, then you will get a longer diameter. So you should be careful when you are doing measurements from the M-mode echocardiogram. Use always the guidance of the 2-dimensional echocardiogram. Do it like this and not like the first one. So this is the most important one if you are taking the when you are measuring the diameters. The next one is always use the 2-dimensional echocardiogram for measuring the volumes. You should not use the cube method or the T-Koch method for measuring the ventricular volumes and the ejection fraction. Use the biplane Simpson method or the area length method for measuring the left ventricular volumes in diastole and systole, and from that you calculate the ejection fraction. Of course, if you are not able to clearly make out the endocardium in more than 2 segments, you should use left ventricular contrast echo. So this is a left ventricular contrast echo. When injected into the peripheral vein, it passes through the right atrium, right ventricle, and crosses the pulmonary circulation, fills the left ventricle, and you can clearly make out the left ventricular endocardium. This measurement is much superior, and the error is very less if you use left ventricular contrast for measuring the left ventricular volumes. The three-dimensional echocardiography is very more accurate than the two-dimensional echocardiogram. Usually the volumes obtained by three-dimensional echocardiography is slightly larger than the volumes which are obtained by two-dimensional biplane Simpson method. Why? Because I see in most of the two-dimensional echocardiogram, the left ventricular apex is foreshortened and it is not included in the measurement. Whereas the left ventricular apex is always included in the left ventricular cast, which we are using the three-dimensional echocardiogram. The second one is, in two-dimensional echocardiography, we use a mathematical formula for measuring the left ventricular volumes by Simpson method or the area length method. Whereas here, we measure the number of volume cells which are present in the left ventricular cast. Otherwise, like pixels, when you are viewing a TV, you call it as a pixel, how many pixels are present. Here, how many volume cells, Vox cells are present inside the left ventricular cavity can be correctly measured, and from that the volume is calculated. So these are the two things. One is the lack of mathematical formula which is involved in measuring the volume, and left ventricular apex is always included in the three-dimensional echocardiographic picture. So three-dimensional echocardiographic volumes are much superior than the two-dimensional echocardiographic volumes. So to again say impress you on that, say M-mode echocardiography should not be used for calculating the volumes and the ejection fraction. So T-Kolch method and the cube method should be abandoned. We should use only the two-dimensional echocardiographic method, especially the biplane Simpson method for measuring the left ventricular diastolic volume, the systolic volume, and the ejection fraction. And the three-dimensional echocardiogram, we can use the say the whole volume pyramid, and from that we can calculate the left ventricular volume in diastole and systole and calculate the ejection fraction. So use the two-dimensional echocardiogram. If you have a three-dimensional echocardiogram, that will be an added advantage. And the systolic dimension, normal systolic dimensions, it's there in the books. You can go through male and female, and the volumes in male and female. And the ejection fraction, you can see in the male is about 52 to 72%, whereas in female it is about 54 to 74%. So these are the normal ejection fraction in male and female. Similarly, you can get the left atrial volume also, and the left atrial volume index also we can measure. Any volume which is above 34 ml per square meter body surface area means that the left atrium is dilated. And most of you will be asking, say, how can you do an eyeballing method? Say the eyeballing method is subjective. We can do it when you are in a hurry like this, when the ejection fraction is completely normal, when the contraction is completely normal. Instead of measuring, you can say the ejection fraction is going to be normal. It's about 60%, like that you can say. But it's very subjective, experience dependent, lack of standardization. There will be large inter and intra-observer variability. The next one is, how about using artificial intelligence? So this is the one artificial intelligence model. It is the Phillips three-dimensional echocardiographic method. So it automatically detects the endocardium, and they have fed in a large amount of data into it, and the machine itself from the three-dimensional echocardiogram immediately produces a cast of the left ventricle and calculates the left ventricular diastolic volume and the systolic volume. So the only thing which you have to acquire is the pyramidal cast from the entire left ventricle from the by using the three-dimensional echocardiogram. When you push a button, then immediately it will mark out the endocardium and calculate the left ventricular volumes. Again, there may be some errors, and it has to be supervised because these measurements depend upon the endocardial delineation. the endocardial delineation may not be so good in all the patients, so we need some supervision for the assessment. That is about the global function of the left ventricle, especially left ventricular diameter, left ventricular volume, and the ejection fraction. Regional function. In the echocardiographic days, we used to say find out the thickness and how it thickens during systole and say this is normal. This is a patient in whom the interventricular septum is thinned out and it's not showing any thickening, so it is most probably infarcted. There is another patient in whom it is hypokinetic. Most probably the septum is normal in thickness, shows some thickening. So we can get an idea about the regional function by using the hemodecardiogram. But regional function is better assessed by the two-dimensional echocardiogram. So this is done from various views. The most important view is the parasternal long axis view, from which we start. Hope you remember all the chambers of the chambers which are shown in the diagram. And we have two important views, sets of views. The short axis view. This is a short axis view at the level of the mitral valve, short axis view at the level of the papillary muscle, and short axis view at the level of the apex. The short axis view at the level of the mitral valve is divided into 6 segments. So this is the interventricular septum, which is divided into anterior septum and the posterior septum. Here, from here to this point, it will be left ventricular anterior wall. Then here it will be anterolateral wall. This will be infralateral wall, and this will be inferior wall. So all of you are clear? There are 6 segments in the left ventricular circle. At the level of the base, we call it basal anteroseptal, basal anterior like this. There are 6 segments at the level of the papillary muscle, similarly, and there are 4 segments at the level of the left ventricular apex: septal, anterior, lateral, and inferior. There are 4 segments. Totally, there are 16 segments in the left ventricle, and these 16 segments can be viewed in the apical 4-chamber view also. In the apical 4-chamber view, you can see in the, say, apical 4-chamber view, it is what we see is the posterior septum and the anterolateral wall. In the 2-chamber view, it is the inferior wall and the anterior wall. In 3-chamber view, it is the infralateral wall and the anteroseptal wall. So we can assess all the 6 segments in this view also. So by looking at the segments, we can find out whether the contraction is normal, reduced, or markedly reduced, or contracting in the opposite segments. And it can be displayed as a bullseye display. You can do it. Why should you have this division? Because this corresponds to the blood supply. You can say if the anterior septum, left ventricular anterior wall are involved, it is almost definitely it is LAD territory which is affected. And if you see the basal portion of the left ventricle is not affected, only the mid-ventricular and the apical portions are affected, then you can say definitely even in the LAD, the obstruction is beyond the first septal perforator. So this much of information we can obtain by the contraction pattern, which is abnormal in these patients. So the right coronary territory will be the inferior septum and the inferior wall, and the rest of the left ventricle is usually supplied by the left circumflex artery. There will be some overlapping and differences in the area of the blood supply of the right coronary artery and the circumflex artery. There will be some variation depending upon which one is dominant, etc. And we can give a scoring. Normal is given a score of 1, hypokinetic is given a score of 2, akinetic is given a score of 3, and dyskinetic will be given a score of 4, and aneurysm will be dyskinetic with an aneurysm will be given a score of 5. So this 1 to 4 score can be totaled and divided by the number of segments to calculate what is called the wall motion score index. So the total number of segments which are visualized and the total score, when it is divided, it gives you the wall motion score index. If the wall motion score index is more than 2, usually it indicates that the patient has got a significant left ventricular wall motion abnormality and that there is a diastolic dysfunction. And we can also assess the left ventricular shape, whether it is more spherical or more normal. from the two-dimensional echocardiogram. Also we can measure the left ventricular mass. And this is one place where the M-mode echocardiogram is still useful. Well, the only thing is there is lack of data by using the two-dimensional echocardiogram and the three-dimensional echocardiogram. The mass has not been, there are not a lack of data. That's why we still use the M-mode echocardiographic method for measuring the left ventricular muscle mass. We measure the interventricular septal thickness, left ventricular posterior wall thickness in diastole, and measure the left ventricular internal diameter in diastole. From that, we can calculate the left ventricular muscle mass and measure and multiply it by 1.08 to get so many grams of left ventricle in that person. We can use the two-dimensional echocardiogram by this method, but it's going to be cumbersome. And again, I told you for a research paper, if you want, you can use it, but then the day-to-day practice is going to be very difficult. But this one is little more easier. The three-dimensional echocardiogram, if it comes into practice in every patient, we can mark out the endocardial volume and the epicardial volume. The difference between the two will give you the myocardial volume. When it is multiplied by 1.08, will give you the left ventricular muscle mass. And there is this mass has been again calculated, and it has been correlated with muscle mass, which is obtained by MRI. The volume and the muscle mass, the gold standard is the MRI, and both have been compared with the MRI data, and it has been found to be excellent correlation between the two. And this is the muscle mass in women and men, normal data from above which we have to call that the patient has got left ventricular hypertrophy. And depending upon these parameters, only the ejection fraction only we decide whether the patient has got heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, or the mid-range ejection fraction. Next, coming to the newer parameters. There are a few other parameters which can be used for assessing the left ventricular systolic function. One of the important parameters is the myocardial strain and strain rate. So this actually, the normal muscle, during ventricular contraction, it may lengthen or shorten. During ventricular contraction, it shortens. So the difference between the diastolic length and the systolic length is calculated. From this, we can measure the strain. So to give you a graphic example, say the initial length is 10 centimeters. During the contraction, it increases to a length of 12 centimeters. The difference between the two is 2 centimeters. 2 divided by 10 will be 20%. Because it is lengthening, it is plus 20%. So the myocardial strain is plus 20% in this patient. In this example, the initial length is 10 centimeters. During contraction, the final length is 8 centimeters. So there is a decrease in the length of 2 centimeters. So this is minus 2 divided by 10 will be minus 20. So the strain will be minus 20. Here you can see this plus 20, this final length can be achieved in 1 second, or it may be achieved in 2 seconds, or it may be achieved in 3 seconds. So when you divide the strain by the seconds which taken for the length to be achieved, then it is called strain rate. So it looks quite simple, and the machine will be able to do it. You need not worry about the formula, etc. And there are two methods by which we can do strain and strain rate. One is by the Doppler method. The second one is the spectral tracking method. The spectral tracking method is the most accurate one, and it is being used on a day-to-day basis. If you see the two-dimensional echocardiogram, you can see some bright spots. They are called speckles. The bright spots are called speckles. So we are tracking the speckles. The number of speckles constitutes a kernels. So we track the speckles during each frame. So this is the first frame, and in the second frame it has moved to this side. The third frame led here, and the fourth frame like this. We can track that speckles in the two-dimensional echocardiogram, From this, the tissue velocity can be calculated, and from this tissue velocity, we can obtain the strain of the two-dimensional in the two-dimensional echocardiogram. And you have to know something about the myocardial fiber orientation also to understand what I am going to tell about the other ones. See, there are circular fibers and the longitudinal fibers which are situated in the left ventricle. The longitudinal fibers are situated in the epicardium and the endocardium. They contract longitudinally. The contraction involved in early systole and atrial systole. Usually it correlates very well with the overall ejection fraction. Whereas there are circumferential fibers in between the epicardial and the endocardial fibers, which are oriented longitudinally. Between the two, it is in the middle of the myocardium, the circumferential fibers are situated. This results in shortening or rotational movement, and their predominant action is during ejection phase and the early diastole. This is best seen in the short axis view. So if you see, this is the heart. Now you are seeing the longitudinal contraction of the heart. Here you identify the speckles and then calculate the strain. This is the short axis view of the heart. Here you identify the speckles and then calculate the velocity, and from this you obtain the strain. This is called longitudinal strain. Okay. Instead of this, so this is an example of a normal longitudinal strain. This is a patient with very abnormal longitudinal strain. You can see the contraction, say upward and lower, downward is very low. Instead of this, take the circumferential fibers, circumferential short axis view. Here you can see two spots. You can measure the velocity of contraction, and from that calculate the strain. This is called the radial strain. The third one is here. Along the circumference, you take two spots and measure the velocity and calculate the strain. This is called the circumferential strain. So in strain itself, there is a longitudinal strain, radial strain, and circumferential strain. This is just for academic purposes. I have told you there is another one is called in the area strain is also there. But what is used nowadays in clinical practice is only longitudinal strain. If you are thorough with that strain, it is enough. So this is a patient, normal person. You can see the contraction is normal in all the views, long axis, four chambers, short axis. And this is the apical views. From this apical view, we have obtained this strain pattern. So the strain is minus 21.1. Anything above minus 17, minus 18, minus 20 will be abnormal, but will be normal. Anything minus 16 or below will be definitely abnormal when the two-dimensional picture is good. So the strain depends upon this two-dimensional echocardiogram. The two-dimensional echocardiographic picture should be really good if you want to have reliable two-dimensional echocardiographic parameters. This is another patient with dilated cardiomyopathy. You can see the contraction is diminished. It is not severe dysfunction. It will be mild to moderate left ventricular dysfunction in this patient. And if you look at the four-chamber view, you can identify again the mild left ventricular dysfunction due to dilated cardiomyopathy. The strain is minus 13.5 in this patient. This is another patient with myocardial infarction. You can obviously visualize the left ventricular aneurysm here. A large left ventricular apical aneurysm, and corresponding to that, you can get a positive strain because it is bulging. So it is the muscle is expanding during systole. You get a positive strain in the mid and apical region in this bullseye segment, and the global strain is markedly diminished. And this is another patient with hypertrophic cardiomyopathy, left ventricular outflow obstruction, marked hypertrophy of the left ventricle. You can see that the left ventricular systolic ejection fraction is completely normal in this patient. But if you look at the global strain, it is markedly diminished because of the abnormality in the muscle fibers even though the ejection fraction is normal, the longitudinal function is markedly diminished and the strain is minus 7.5. So this is the second parameter which can be used, and it is very useful in assessing the left ventricular systolic function. Then the other parameters I'll just mention and I'll finish within this 1 minute. These are the other parameters. You can use the basal fractional shortening, the myocardial performance index, otherwise called as the TAE index, and the other one is the left ventricular say tissue Doppler imaging, and the desynchrony measurements also can be done from the for assessing the systolic function. Will not go into the detail. I think you all of you know about that. It is not used now that much in day-to-day clinical practice. It is mainly for your exam purposes. You can read about it. Thank you.